Good afternoon, everyone. My name is Jackie Lizer. I'm a manager with the CAQH core team, and I just want to welcome you all to our webinar this afternoon. We'll be talking a bit about updates that the core team has been working on these past few months and what's coming up in the year ahead. Before we get started, I do want to run through just some brief Zoom logistics with you all. You might notice the banner at the top of your screen. The session is being recorded. All attendants and registrants will receive a link after the presentation within the next 1 to 2 business days with access to the recording and a copy of the slide deck that you can download afterwards. Your microphones will be muted during the webinar, but if you do have any questions, you can submit them at any time throughout the session. If you just hover over the bottom of your screen, you should see the Zoom menu pop up, and you can communicate a question with that question's Q&A button at the bottom of your screen. I'm going to go through our agenda before I pass things over to our team. We'll kick things off with a brief core overview. We'll talk a little bit about the 2024 policy landscape, and then we'll spend a lot of time talking about our 2024 initiatives. So that includes the status of some of our draft operating rules, a new issue brief that was released recently related to CPT-2 billing, and information about upcoming new rule development for the rest of this year. We'll wrap things up with some information about our certification program. We'll have time for Q&A at the end, and then we'll end with a call to action. With that, I'm going to go ahead and pass things over to Erin Weber to get us started.
Great. Thanks so much, Jackie. And thanks everyone for joining us today. I am Erin Weber, and I am the Chief Policy and Research Officer at CAQH. We have a lot of really exciting updates for you today. Our team has been really busy kicking off the new year with lots of exciting things. And as you all well know, there's quite a bit going on in the industry as well to talk about. So before we launch into all of the information we want to share today, for those of you that are newer to our organization, I want to share a brief overview on the work that we do. CORE is a multi-stakeholder industry initiative with a mission to develop operating rules to improve the exchange of information in healthcare. So operating rules are really business rules that help improve interoperability between trading partners. We are designated by the Department of Health and Human Services as the National Operating Rule Authoring Entity. And because of that, several core operating rules, in fact, about 10, are federally mandated under HIPAA, which means that all HIPAA-covered entities have to be in conformance with those operating rule requirements. We also have a number of operating rules that are available for voluntary adoption, and organizations choose to do so because of the ROI associated with exchanging transactions in a more streamlined and uniformed way. There is a lot of information being exchanged on a regular basis in our healthcare system. And in fact, the CAQH index report, shared that this year, there is an $18 billion opportunity for the industry in savings if we were to transition to fully automated transactions across the healthcare revenue cycle. And so that's about 22% of our spend. So as we go through this presentation, one of the things that is top of mind for our participants and for the industry is how can we get to those cost savings? And operating rules are certainly one tool to do that. CORE is made up of industry stakeholders, including health plans, providers, vendors, associations, and other government industry stakeholders who come together to develop operating rule requirements. So CORE, as a staff person, we are just facilitators of this work because our participants are volunteers and have other full-time jobs. So we support the development of the operating rules, but it truly is an industry activity, and the rules are generated by the industry itself. On the next slide, I just want to highlight that the operating rules we have today, there are 8 sets of core operating rules really spanning the entire healthcare revenue cycle, from eligibility verification to prior authorization to claim submission and payment. And then there's also rules for the enrollment of members into a health plan and the payments that run between, for example, an employer and a health plan. The operating rules are defined under the ACA as the necessary business rules and guidelines for the electronic exchange of information, not defined by a standard. And that's really important. Operating rules build on standards and they enhance standards. They can't conflict with the requirements that are already in a standard, and they can't duplicate those requirements. So there is an iterative process related to the evolution of operating rules, and as standards are updated and may include operating rule requirements, those requirements then are pulled out of operating rules. On the next slide, I just want to highlight our core participating organizations because we're very grateful for their support and their engagement in the development of the operating rules. This year already, we have 3 new participating organizations: Indedic, which supports the dental industry, so Secumet Advisors, as well as the National Association of Health Access Managers. And that association represents provider, hospital, and health system staff that are really working on the front end of the revenue cycle. So processing eligibility and prior authorizations that really feel the impact of automation in their day-to-day roles. Next slide. One of the really unique things about CORE is that we are governed by a multi-stakeholder board of directors. And this year we have welcomed 3 new board members to the CORE board. There are equal parts health plan and provider members on the board, as well as vendor representatives. So you can see here we have 3 new health plan representatives from United, Centene, and Kaiser, and we're really excited to have their expertise and support as we move forward into 2024. I'm now going to turn the presentation over to my colleague, Mike Phillips, to give an update on some of the policy activity that is impacting the interoperability space at this time. Mike?
Yeah, thanks, Erin, and thank you for that great overview. If you can advance to the next slide, I'll give a very high-level overview of some of the policy targets that CORE is tracking and directly interacting with. First, and no surprise to anyone on the call today, is the recently finalized interoperability and prior authorization rule that was released out to industry on January 19th, 2024. The very high-level recap of this, again, many of you are actively culling through this and learning everything about it, but it establishes the use of FHIR-based APIs for data exchange and prior authorization, and provides greater stringency for response and decision timing around the prior authorization pathway. Right now, CORE is coordinating both internally at CAQH and with our industry stakeholders to catalog return on investment and support a conformant, optimized implementation pathway. So like many of you, very actively working here to demonstrate the importance of it and the benefit of it out to industry. Recently, there was a final rule, proposed rule release around the No Surprises Act and the independent dispute resolution process. CORE issued a response to this on February 5th, 2024, right when the comment period was closing. It had been extended. The rule itself operationalizes aspects of the IDR process, but something that was included in the preamble to that rule was requiring the use of CARCs and RARCs to communicate provisions of the Act. As many of you are familiar, CORE has a set of 4 core-defined business scenarios that include a maximum set of CARC and RARC code combinations that is currently mandated as an operating rule. So we took a vested interest in this rule and responded requesting coordination between CORE and the tri-departments and OPM when creating code combination guidance around generally a price transparency business scenario. I know that many folks, as you're registering for this, submitted seed questions around the need for additional CORE business scenarios and code combinations. And I will share that price transparency was on our radar for code combinations. So this was beneficial to initiate a conversation with our federal partners. We're also monitoring the imminent release of the Health Data and Interoperability, or HDI2, proposed rule coming out of ONC that we expect advances interoperability through standards and certification, and serves as somewhat of a complement or is inclusive of requirements for prior authorization. Right now, we're very much monitoring for the release of proposed rulemaking for any potential impacts to ongoing core initiatives, and in general, just the advancement of prior authorization across the industry. As we know, it's a burdensome workflow that is quickly gaining clarity through interventions from federal and other partners. Next slide, please. Branching into later into the year, we are expecting an interim final rule at some point in 2024, and Aaron will share more on this in a moment, but this would include updated new operating rules for connectivity, eligibility and benefits, claim status, and payment and remittance that were recommended for adoption by NCVHS on June 30th of 2023. CORE is prepared to educate about the contents of these rules and the industry benefit for when that IFR hits. We're also willing to engage, obviously, in advance of that IFR hitting. I believe that the industry is still awaiting on, and CORE is monitoring the final rule SAGE release of attachment standards. In late 2022, CMS proposed attachment standards naming the X12 275 and the HL7 CCCDA standards for the exchange of healthcare attachments for claims and prior authorization transactions. We do anticipate that the final regulation will be released sometime in 2024, likely inclusive of the named standards, as well as consideration of any overlapping regulations, such as the previously mentioned interoperability and prior auth reg. And then lastly, on our sort of long-term radar at this point is once again regarding the No Surprises Act and the advanced explanation of benefits. We expect likely in Q1, well, what's currently on the long-term agenda is Q1 2025, proposed requirements for the creation and the content of AEOB for covered lives. We're monitoring the release, and one reason why we're particularly interested in this in CORE is there was a request for information from the tri-departments in OPM in fall of 2022, soliciting input about requirements for the creation of the advanced explanation of benefits, as well as other components of the No Surprises Act. So we anticipate that this proposed rulemaking will be inclusive of insights both from what CORE submitted as well as our industry partners. So just a peek of some of the things on the horizon. Very exciting time in federal and state rulemaking processes. But I'll hand it back to Aaron at this point to discuss some of the NCVHS related rules.
Great, thanks, Mike. And Mike alluded to this already, but this slide is really the whole how a bill becomes a law thing. So for operating rules, once they are approved by the CORE participants, and we'll talk a little bit later today about what that process looks like, the CORE board determines whether or not it is time to send a set of rules to the National Committee on Vital and Health Statistics, which is a federal advisory committee to HHS on topics related to HIPAA administrative simplification, among others. And so once they agree on a set of rules, they will send a letter, and that triggers a process within NCVHS to collect industry feedback through a request for information process, as well as through hearings where they solicit presentations and feedback from industry on the proposed rules. That process occurred over the last year or two. Mike mentioned that NCVHS did make a recommendation on a set of operating rules. And we are now awaiting the interim final rule. CMS, we know, is actively working to develop this interim final rule, and it is slowly making its way through the federal rulemaking process. On the next slide, I just want to highlight what was included in the NCVHS recommendation and what we would anticipate to be in that interim final rule. Several of our previously mandated operating rules are updated in this recommendation. Really to meet current and emerging business needs around system availability, data content in the eligibility transactions to address things like telehealth, prior authorization, more complex benefit designs. We've updated our connectivity rule because it was first developed, the version that's currently mandated 10 years ago. And we all know that technology has made some strides in that time frame. So in addition to a new rule around the sharing of patient attribution information in the eligibility transaction. So there's lots of good content in these rules. I think they will be really beneficial to the industry when implemented on a wide scale and really increase the value of those existing operating rules. While we're waiting for the IFR, I would encourage you to think about and begin planning for your implementation. And we have a number of resources available on our website to help you do that. And we'll talk about core certification in a bit, but that is a great way to assure that your organization is in conformance with the most recent versions of the operating rules. I will now turn the presentation over to, let's see, my colleague, Mike again, to talk about our 2024 initiatives, or am I still going? It has been a crazy day. So slide 14. Oh, this is still me. Okay, so I'm going to keep going here. So in 2024, if we can go to the next slide, I want to highlight some of the work that we've been doing. Even though we have the set of rules with NCVHS, we continue to update and create new rule requirements to address other evolving industry needs. And I mentioned earlier that all of our rules go through a voting and approval process, starting with subgroups that are individuals from our core participating organizations. They are chaired by representatives from those groups that really come to consensus on a set of requirements within those operating rules. Then they go to the work groups, which really oversee the work of the subgroups. They review that work, and there are voting and quorum requirements at that level and every level of voting from there forward. At the full core voting membership, only those organizations that would implement the operating rules, so those that are exchanging the transactions, have a vote, and that requires a 60% quorum and a 2/3 vote. And that is because these are the organizations that have to make the investment to implement the operating rules. And so it's really critical that they approve and see the value in the proposed rules. And then the final step is the core board. So we do have some draft rules going through this process now. If we want to move to the next slide. Most recently, we have had a set of new and draft rules complete the all core vote process. I believe all rules received at least 86% support from the core participating organizations. We have rules around value-based payments. These are new and updated rules that standardize the exchange of socio-demographic information at the point of member enrollment. We have new draft healthcare claim operating rules related to both claim acknowledgements and the claim itself, bringing clarity to telehealth billing, addressing coordination of benefits, and really trying to get at the challenges the industry is having related to denials. Can we help to improve that first pass claims rate with these requirements? And finally, we've updated our EFT and ERA enrollment operating rules. And these are rules that are federally mandated, but the industry has identified additional business needs around fraud detection, disclosure of fees related to healthcare payments, and notifications that would be helpful to providers as part of the enrollment process. So those rules have been updated as well. The core board is convening later this month to review and vote on these rules. If approved, they will be published to the industry and available for industry adoption. Next slide. Now I am going to turn the presentation over to my colleague Mike again to talk about some of our pilot work. Mike?
Yeah, even I got confused there. It's yeah, no, thanks so much. And I'm excited to share with you recently some highlights from a recently released issue brief on CPT-2 billing. For background, CPT codes are often used in quality incentive or value-based contracts to document adherence to best practices of care or other care processes. We were fortunate enough to partner with one of our core participants, Athena Health, EHR and vendor based out of Watertown, Massachusetts, to highlight a tool that they have on their Athena One platform, a CPT2 automation tool, which assists with the determination, recording, review, and submission of CPT2 codes on a claim to really help streamline that process that can otherwise be quite burdensome. Sometimes finding CPT2 codes requires extensive chart reviews and a lot of manual processes to come up with the clinical justification for including these codes on a claim. The hypothesis was that by using this tool, that practices would be able to win greater efficiency overall, that they can reduce the number of FTEs devoted or maximize or optimize the amount of time that they spend coding CPT2 codes or other quality data codes across these 4 primary tasks that I mentioned before: determination, recording, review, and submission. Athena and Core collaborated to issue a survey out to the current users of this tool, querying about how these resources were devoted prior to implementing the CPT2 tool and after implementation of the CPT2 tool. And the results of the survey were actually quite interesting. One thing that we saw that the number of FTEs that are devoted to quality data coding and specifically CPT2 coding actually remain stable between pre and post implementation periods for the of the CPT2 automation tool. But what we saw, despite that stability, is FTE time shifted away from traditionally more burdensome tasks. So there was a lot of evidence in what practices reported that while resources weren't reduced, they were able to use their time more effectively. So you saw FTE time shift away from burdensome tasks or time-consuming tasks like determination, and shift more into tasks of assuring that the submission was correct. And these are typically seen by practices as less of a heavy lift. You know, it doesn't require as much of a chart review, and now we can just sort of move it along to submitting and fulfilling the contractual or the quality obligations of the value-based contract. It should be noted as well that effects were more pronounced in practices who chose to go with a full automated route versus a partially automated route. And what this means is that some practices under the partial automation chose to maintain some manual oversight of the process. Other practices decided to automate fully from determination all the way through to submission. So that FTE time shift was more pronounced when a practice chose that full automation pathway. So overall, and I should note that the this issue brief is posted on our website right now for your review. And overall, though the results didn't show significant resource reduction, the takeaway was that the tool is valuable to optimize FTE allocation. And there were some results in there that suggested that it enhances engagement with incentive-based or value-based contracts, meaning that a tool like this that automates one of the most burdensome aspects of participation in value-based care can help establish an infrastructure for practices who otherwise want to participate, but saw that the cost of it or sort of just the manual workflow of it, saw that as an overall burden. So this removes some of those barriers and can help facilitate the adoption of these very important value-based or incentive-based contracts. So once again, thank you to Athena Health for collaborating with us on that. And it was really a rewarding experience. And we're available to answer any questions as you have the opportunity to read through the issue brief. So I am going to pause there and pass it over to my colleague, Pete Benziger, for a claim status update. Pete, thank you so much.
Thank you, Mike. Hopefully everyone can hear and see me. I can hear myself, so that's good. But we're talking about claim status at the moment. And as we turn the page here, perfect. Over the last 2.5, actually 3 months that I'm thinking how fast time flies, Core completed an environmental scan on the topic of claim status. An environmental scan is essentially a research project to assess industry's desire or need, however you'd like to put it, for operating rules related to this transaction specifically. So in doing so, we worked through the methodology outlined on the top half of this slide here. We went through a detailed literature review over 20 interviews, and we're sure to check out who all is on the line here. There are some folks who we spoke with. Thank you for spending your time with us. And we also completed a quantitative analysis of the different types of the claim status transaction. Safe to say, it was a thorough review. And spoiler alert, it led us to the conclusion that the industry does want and definitely needs the support that an operating rule could bring to the claim status. Also, it perhaps unintentionally led me, I have a new favorite transaction. So thank you in advance for bearing with my enthusiasm about claim status. If anybody is not familiar about or with the claim status transaction, it's a HIPAA mandated transaction, also known as the 276, 277 in X12 lingo. The 276 is the claim status inquiry, and the 277 is the claim status response. What it does is give providers a snapshot of where a claim is within the adjudication process at a specific point in time. And that's worthy of reiterating that it's at a specific point in time, because in other words, you could send a claim status inquiry one day and get a pending adjudication or something similar along those lines one day. And then a couple of days later, perhaps a week later, you could send an inquiry for the same claim and get a claim paid response. So with that example in mind, the business case for the transaction, we understand from industry is very strong. If you're a provider, learning that a claim has been paid, for example, tells you that you should be looking for some type of payment in the near future that has not come in already. There are major benefits there in helping you operate your business office effectively. Another example, if you're a provider learning that a claim status is pended for missing some type of documentation, that tells you that the claim has not yet been completely denied, and you might have an opportunity to coordinate with the health plan to share that documentation and fix whatever information is missing, hopefully getting your claim paid. The alternative to that being you wait, in that pending example, to learn of the missing documentation problem when the 835 comes around a couple weeks later in the denial. If it's a denial, you got to start the rebilling process. So pulling up some of that understanding of why you might be denied, if your health plan, you can work with your health plan to get them the information you need to adjudicate the claim. So perhaps surprisingly, maybe not so surprisingly to others in our research, CORE learned that the claim status transaction is not used exactly in that hypothetical manner that I just outlined for a few reasons outlined in the bottom half of this slide. First, understanding what the error codes, which are claim status codes and claim status category codes, those familiar with them, are communicating in the claim status response is very difficult because they're ambiguous in some cases, and they're not standardized across the industry. There's a lot of them, and they can be very helpful. They're used in different ways. So an operating rule can bring clarity to the meaning of those codes, as we've done in the past in our code combinations work and business scenario development efforts. That's one opportunity. Another opportunity is some health plans, for example, require different criteria in the claim status inquiry beyond what the standard, the current standard might require. So for example, we assessed that different data points required by health plans. If we did that, we could build a minimum required data set. And in building a minimum required data set, we would expect that health plans more consistently get what they need from providers to find the claim that needs to be given a status update for, and providers see fewer responses that indicate claim not found or something similar. Finally, on the right side of the screen, that the claim status is just a snapshot in time makes it a perfect use case for making it a real-time transaction. You should be able to click a button and get your claim status response admit in some cases with some vendors and health plans, you can do that, but for a variety of reasons, including it's just a difficult project to undertake if you've not already accommodated the real-time transaction capabilities. Adoption of real-time claims status transactions is limited. So the rule development opportunity here, as we see it, is aligning on best practices or other foundational support that make it easier for vendors and health plans to build out their real-time claim status capabilities. So today, in contrast to that notion, trading partners call, fax, send Excel workbooks, and use portals to find claim status information, which leads me to the last thing I'll highlight, a shout out for our insights team metrics from the 2023 CAQH index. The combined potential annual cost savings for medical and dental industries related to moving to a fully electronic claim status transaction is $3.7 billion with a B. The average medical provider time savings for a single transaction is 17 minutes. And for a dental provider, that number is 14 minutes. So folks are spending a lot of time doing this highly valuable transaction manually. At the end of the day, what we see based off of our research and discussions is a claim status transaction that is informative and easy to understand as a vehicle for conveying what providers need to do to help a health plan adjudicate their claim, get the information they need to adjudicate their claim earlier in the processing workflow than similar information might be conveyed in a remittance advice. So we hope that is a good background content, gets you excited about our work efforts related to claim status, because we intend to launch a subgroup in May, start recruitment for that subgroup in April, and publish an issue brief with greater detail about the rule development opportunities here for the transaction in the coming weeks. I believe I'm transitioning speaking roles back to Erin here. All right, there you are. Don't hesitate to reach out with questions about claim status.
Absolutely. Thanks, Pete. I'm going to give a quick update on this next area of focus for CORE in 2024, and it's related to medication coverage details included on the eligibility transaction when that medication is covered under the medical benefit. So when that happens, it becomes part of the HIPAA 270, 271 transaction. But right now, most providers are only getting generic information at the service type code level and not enough detail to be able to automate this part of the medication eligibility workflow. And so that means it's dropping to manual, it's very costly and time consuming for providers. So we are working with NCPDP, and we've done a lot of research over the last year as to what are the real challenges here and opportunities to drive towards automation. And some of the challenges relate to the transaction limitations and what's actually required versus not required right now. It's complex to navigate this type of care. There's a reliance on PBMs in this space, and so that is causing some data islands, as well as just coding complexities around medications. So that really revealed some key opportunities to NCPDP and CORE around how we can promote interoperability through operating rules. And of course, the first is to expand usage of the 278. Could you require use of certain J codes or others to really get at that procedure level detail that might be needed to show the medical benefit coverage? The need for real-time verification, getting assurances that this information would be returned in real time would be incredibly helpful for the provider. Thinking about scoping data exchange requirements, and that's really about enhanced transparency around coverage, eliminating discrepancies, and thinking about procedure-driven coverage into the eligibility response. And then finally, there's a challenge around aligning varying requirements across health plans. What medications are covered under the medical versus pharmacy benefit varies between plans, and the workflows and the policies and when the policies are updated, none of that is really happening in a consistent way, which means that providers have to maintain different workflows for different plans, which is causing additional burden. On the next slide, just to highlight some of the kind of overarching rule development work we have in 2024, we will be launching a task group to evaluate some of these medication coverage, especially medication opportunities within the eligibility and benefits rules, as well as looking at dental and mental health benefits as well. So some of those carve-out benefits, it's really becoming more urgent for the industry and for providers to be able to access that coverage information in real time in an automated way. So we are really focused on working through that this year with the participating organizations. Pete talked about some of the work we're going to be doing around claims, but really thinking through ensuring consistent information is returned at every step along the claim adjudication process. So we have new claims data content rules coming out in the coming weeks. And then with this focus on claim status, we really hope that that whole adjudication workflow can be consistent across the industry. And then Mike mentioned our code combinations work as part of his policy update. We are going to be conducting a market-based review of the code combinations this year and thinking about, do we need any new business scenarios to help address some of the kind of emerging businesses that are coming out in the industry where we're getting feedback, and we've had some emergency code combinations adjustments. We've seen some increases in that this year, which says there may be a need to create new business scenarios to support that. So that will be launching in Q3. And then I am now going to turn it over to my colleague, Adam Nichols, who is our manager of certification, to share some updates on the core certification front. Adam?
Excellent. Thank you. Thanks, Erin. Today, I'd like to provide just a high-level overview of the core certification program, along with a mention of the core certified organizations, and ending off and highlighting the recertification program. So, as you all know and are aware, the operating rules are published. CAQH Core offers a certification and testing program to really ensure that the industry has successfully implemented operating rules and associated standards as defined and required by regulations or trading partner agreements. So Core launched the Core certification program really to support organizations implementing those operating rules, and that the Core certification program validates and demonstrates conformance to the rules that organizations implemented to ensure that their systems are up to date. So this program was developed by the industry, for the industry, through a transparent and multi-stakeholder process, similar to the process in which the operating rules themselves were developed. One of the primary reasons as to why an organization chooses to pursue core certification or recertification, for that matter, is really to ensure the conformance to federal mandates. The core certification is also a good way to prepare for compliance reviews, and that CMS has been actively engaged in auditing organizations as a part of their compliance review program. The certification seal reduces the time to complete those audit reviews such as these. Core certification is also positioned to help organizations assess, demonstrate, and document and certify conformance with federally mandated standards and operating rules. So this works to build confidence with these organizations in the event of those audits. A few other things: the certification program is also designed to ensure that the IT systems and their products are aligned with federally recognized and industry developed operating rules and underlying standards. Overall, the core certification program offers cost savings, industry recognition, and a market advantage for organizations like health plans, clearinghouses, and vendors, or any other organization that exchanges healthcare information. And to date, we have awarded 410 certifications. So looking at that next slide, provided on this, you see a list of both health plan, clearinghouses, and vendor organizations that are currently core certified on the applicable operating rules associated with the transactions that they process. So a number of different organizations that you can see there. And on the next slide, I really wanted to congratulate our recently certified and initial certified organizations on pursuing the operating rules and the latest updates to the rules themselves. Last but not least, on the next slide, one item I'd like to talk about is really a key enhancement to the CAQH program, core program that's made to the created in 2020 was adding in the requirements for recertification. So we really believe that with the evolving technology, mergers, acquisitions, and system upgrades, there's really a need to assess that ongoing conformance to the operating rules to maintain program integrity. Further, recertification enables organizations to align with healthcare needs for the operating rules when the rule requirements are updated over time. So in terms of timelines, core certified entities will be required to recertify every 3 years. These renewals may occur during any time of the calendar year based off of the initial year of core certification. After communicating intent to recertify, recertification testing must be completed within 180 days. If there is a lapse in renewing in that certification, CAQH Core will proceed with engaging an organization on decertification. Any updates to the CAQH Core operating rules will be incorporated within the recertification process, and at a minimum, entities must implement versions of the operating rules that have been published 24 months prior to the core certification seal renewal date. So meaning as organizations approach their recertification dates, they must consider and evaluate if they will need to implement new or updated operating rule requirements in order to recertify. The recertification is now required for organizations. So if your organization was last issued, let's say, a recertification in 2021, you would need to recertify by the end of this year to keep your recertification active. If you are a core certified organization, please feel free to contact us if you're unsure or when you need to recertify by. So I'll hand the call back over to Erin. Thank you today.
Great, thanks, Adam. We're nearing the end of the webinar, and I just want to take a minute to thank you all for joining us today. You can see that the core participants and really the entire industry puts a tremendous amount of work into the development of the operating rules, the certification program, and then more broadly, all of the policy efforts that are underway across the industry to provide feedback to the federal government and really make sure we're being thoughtful as we move to a more interoperable ecosystem. So really appreciate your time today, but more importantly, your time and commitment to the broader mission of our healthcare industry. For those that haven't been as engaged, I would ask you to consider becoming a core participant, joining in the rule development process to hear more about what your colleagues are experiencing, how we can come together as disparate stakeholders and really think through how we can work together to identify solutions and rules and requirements that benefit the entire industry. Encourage you to think about getting certified or recertified depending on the timeline or your engagement thus far. And to participate in pilots, we are going to be looking at a number of opportunities over the next year to help measure and demonstrate the value of some of the newer operating rule requirements and draft operating rule requirements, as well as on our insights side of the organization, our research team, thinking through as we're making this transition, particularly around prior auth from a more EDI to more API driven environment. How can we track and make sure that the return on investment is really being seen and measured in a meaningful way? So we are excited to support the industry in that way as well through collaborative efforts. So if you have any questions, please shoot us an email or a comment, and I will turn it over to Jackie now to moderate some questions. Jackie?
Great. Thanks, Erin. Just a reminder, if you have any questions, please go ahead and submit them using that questions button at the bottom of your screen. I do have a few questions to get us started though. And the first one is for Mike. It's a specific question about the new single patient attribution rule. Does this apply to any type of value-based care or payment model?
Yeah, it's a great question. Excuse me, I'm sorry. It's a great question. Let me first say we're very excited by the recommendation from NCBHS for adoption of this rule. It's the first, to the best of our knowledge, first value-based care specific operating rule that has been formally recommended for adoption by HHS, CMS and HHS. So to answer your question directly now, after I show off about it a little bit, is no, it does not apply to every type of value-based care model. This really addresses population health-based models, accountable care organizations, and the like, which tend to fall under the HCP land categorization of category 3 and 4 models. As our participants were reaching consensus, it seemed to make the most sense at that time to really frame it around those models. There may be future opportunity as we explore these value-based care concepts with our participants to expand attribution to other types of models, such as episodic care. But those are topics that we're still exploring and will raise with our participants in our rule development process. So, but good question. Thank you, Jackie.
Great. Thanks, Mike. This next question, it might be top of mind for folks just because it's been in the news recently, but it's for you, Erin. How does the Change Healthcare breach impact operating rules, and how can redundancy be built into the process in case of a breach?
Yeah, well, I think, thinking more broadly about the industry, and if you think to the CAQH index report and how many billions of electronic transactions are sent across our industry really each and every day, knowing that, we know that the impact of the cyber attack has been significant based on what we're reading and seeing across the industry. We have gotten a few questions related to operating rule requirements because there are operating rule requirements around system availability. It's really important to have systems up and running a certain percentage of the time. The current federally mandated rules say 86% of the time. Updated rules move up to 90% of the time, and there's requirements around notifications around downtime and emergency unscheduled downtime. So we've gotten a few questions around those. And also, availability of electronic enrollment platforms for EFT and ERA, which is a requirement of the rule. For organizations that are concerned about their HIPAA compliance, we certainly encourage you to reach out to the CMS National Standards Group team, as they really have the authority there to determine areas of compliance. If you're concerned about a trading partner who may not be in compliance, and this is really outside the scope of the Change Healthcare situation, but really for anyone who's having challenges receiving any HIPAA covered transactions or worried about compliance with the operating rules, CMS does have a complaint driven tool called Asset, where you can submit information and they will conduct an investigation to determine if there is non-compliance and work through a remediation program. Similarly, from a core certification perspective, we do have a complaint-driven process as well for any organizations that's core certified in both the federally mandated and the voluntary operating rules. So I would encourage you, if you're having challenges, to go down that path. But I think we're also at the point in the industry where, everyone's experiencing a little bit of pain, and a little bit of grace is really important right now to help us all move through this in the most thoughtful way and prudent way possible.
Great. Thanks, Erin. I have one more question left, unless we get any last minute questions submitted. And that question is, when do you see HL7 FHIR API support for service authorizations and attachments to be implemented by both payers and providers?
Good question. So Mike covered some information about the final rule that came out of CMS earlier this year related to requirements to implement FHIR APIs for the exchange of prior authorization information. The implementation deadlines for those are January 1 of 2027. So we anticipate really a 3-year transition plan as organizations prepare to go down that implementation path. So most folks are still really evaluating and interpreting the final rule and beginning to think about their implementation plans. I would expect over the next 2 to 3 years, we'll see that transition start to occur across the industry. I'm really excited because the CAQH index has always tracked prior authorization automation, and traditionally we've looked at the HIPAA mandated 278 rule. And for those who are following this closely, you will know that CMS actually issued enforcement discretion related to that requirement so that organizations can elect to use a FHIR API for prior authorization in lieu of the 278. And as the CAQH index collects data over the next 2 to 3 years, we'll be asking about, as we always do, manual, partially electronic, which is portals and other tools like that, and the 278, but also FHIR APIs. So I'm excited to see how that data trends out over the next 2 to 3 years as organizations begin to implement these requirements.
Great, thanks, Erin. I didn't see any more questions come through, so we might just wrap up a few minutes early. But on that note, yep, go ahead.
Oh, I was just gonna say one more thing. I know many in the industry will be at HIMSS next week, and we do have a presentation at HIMSS with our core board chair, who is Linda Reed, who is the Chief Information Officer at St. Joseph's Health in New Jersey, a safety net hospital system. And so that presentation is Tuesday afternoon. So I would encourage you to come join us and certainly ask any questions. Would love to get to know you in person at HIMSS as well. So appreciate that.
Yeah, absolutely. And if any other questions do come up, just on the next slide, we have our email address, core@caqh.org. Please don't ever hesitate to reach out to our team. We're happy to answer any questions that you might have. And with that, just thank you all so much for joining us this afternoon, and hope you have a great rest of your week. Thanks, everyone.
Thanks, Jackie.